Hello, I am Parameswaran Hari. I'm a professor of medicine at the Medical College of Wisconsin in Milwaukee, Wisconsin. I am here at the American Society of Hematology meetings in San Francisco, presenting data from the meta-analysis of pharmacotherapy versus observation for the management of patients with smoldering multiple myeloma. So this study was conducted to answer the question, is there any benefit for treatment of patients with smoldering multiple myeloma with either pharmacological therapies or bone strengthening therapies such as bisphosphonates? The study population was identified from 12 different individual studies that were conducted between 1998 and 2014, and we selected studies based on their quality of the results and the findings reported therein, and pooled all of them into a combined analysis known as a meta-analysis. From starting with a pool of almost 10,000 studies, we narrowed down them to 8 studies of sufficient data quality that could be pooled into a meta-analysis, and the overall number of patients included in the meta-analysis was 700. These patients were all participating in randomized studies that either compared conventional chemotherapy agents such as melphalan, immunomodulatory agents such as thalidomide or lenalidomide, with or without bisphosphonates, pamidronate or zoledronic acid, versus observation as the strategy for preventing progression of smoldering multiple myeloma to active myeloma. The methodology was by a technique known as the preferred reporting items for systematic review and meta-analysis, which is the validated way of conducting such meta-analysis. And the therapeutic interventions that we looked at included thalidomide in 2 cases, bisphosphonates with pamidronate in 1 case, zoledronic acid in 2 cases, and a combination in 2 other cases. And most importantly, the more recent study that was presented by the Spanish group with lenalidomide and dexamethasone versus observation in smoldering myeloma. So all these studies were included in our analysis. Our findings are as follows. We found that there was an overall benefit with anti-neoplastic therapy of any sort in patients receiving treatment for smoldering multiple myeloma with these agents. We also found that there was an improvement in progression-free survival in those receiving either chemotherapeutic agents such as melphalan or IMiDs, but not for those receiving bisphosphonates only as treatment. So the benefit was limited to patients receiving chemotherapeutic agents with or without bisphosphonates versus those receiving observation or bisphosphonates alone. We did not have toxicities or other additional adverse events in this study because this was a meta-analysis. The only endpoints that we looked at were progression-free survival and overall survival. On the basis of this, we can come to the following conclusions. Smoldering myeloma represents about 15% of all patients who are recognized with multiple myeloma. Recently, the International Myeloma Working Group has redefined the myeloma defining endpoints for patients with this condition, so that previously people who were considered smoldering myeloma, some of them would now be considered active myeloma requiring treatment or symptomatic myeloma. Thus, there is a subset of smoldering myeloma patients who would benefit from treatment. Our hypothesis is that these are the patients who primarily benefited from this, from the studies that we are reporting in this meta-analysis. This study and the others that have done in a similar vein show that there is at least a small subgroup of patients who do benefit from early treatment of smoldering multiple myeloma. And the important thing to keep in mind is that smoldering multiple myeloma is not a biological definition, it's an arbitrary definition, and depending on the risk or the benefit of the treatments that we can give for patients with smoldering multiple myeloma, we can redefine that line. In fact, this ties in with the more recent redefinition of multiple myeloma that was performed by the International Myeloma Working Group and published in Lancet Oncology in 2014. I would encourage everyone to use those guidelines for treatment of multiple myeloma, and our study bolsters their conclusions.
Okay, recording.
I am here at the American Society of Hematology meetings in San Francisco, presenting data from the Approximab and dexamethasone study of patients with relapsed or refractory multiple myeloma from the dose escalation portion of the phase 1b/2 multicenter open label study.
Okay, cool. Now hold on just 1 second.
Okay, recording.
Approximab is a orally administered, irreversible proteasome inhibitor belonging to the epoxy ketone class of proteasome inhibitors that binds to its proteasome targets in a sustained fashion. The hypothesis is that this agent is active in patients with relapsed and or refractory multiple myeloma.
Okay.
Okay, recording.
This is a multi-center open label phase 1b trial with a follow-on phase 2 portion. Patients are eligible who have relapsed and or refractory myeloma and have been exposed to 1 to 5 prior lines of therapy, including at least one regimen that should have included lenalidomide and or bortezomib. The primary objectives in the phase 1 portion were to discover and determine the maximum tolerated dose, and the phase 2 portion is to determine the efficacy of the drug.
Okay, great.
Okay, recording.
Patients on this trial receive Approximab as an oral agent in 2 different dosing schema. One schema would include 2 consecutive days of Approximab and dexamethasone given every week. This we call the 2/7 dosing schedule. And the other dosing schema included 5 days of treatment every 14 days with dexamethasone on 2 days and Approximab on 5 consecutive days every 14 days. The starting dose of Approximab was 210 milligrams in both dosing schedules, and the plan would be to go up with 30 milligram dose increases in a classic 3x3 design, which means every 3 patients we would stop and assess toxicity, and if there are no toxicity, go up to the next level.
Recording.
The major toxicities that we observed were hematological, including thrombocytopenia and anemia. In addition, we found that there were gastrointestinal toxicities, especially at the 5/14 dosing schedule. In the 2/7 dosing schedule, we did have gastrointestinal toxicities that were mostly grade 1 and 2 with a limited amount of grade 3 toxicities. Overall, the drug was reasonably well tolerated, especially in the 2/7 dosing schedule. We have not reached a maximum tolerated dose schedule or a preferred dosing schema yet after 35 patients have been accrued.
Okay. Quick question.
Right, recording.
Preliminary responses, especially with the 2/7 dosing schedule, have been very promising, with partial responses observed in 35% of patients, with 17 evaluable patients. Out of the 17 evaluable patients, we have 6 partial responses, and the 2/7 dosing schedule was more tolerable, and patients were able to sustain that dosing schema for a longer period of time. In the 5/14 dosing schedule, we've had 1 response out of a total of 14 evaluable patients.
Great. Okay. So.
All right, recording.
In summary, I would conclude that Approximab as an irreversible proteasome inhibitor that's orally bioavailable has activity as a single agent and in a combination with dexamethasone in patients with relapsed myeloma. We did find gastrointestinal toxicity, and a new formulation is being tested now with the hope of finding a maximum tolerated dose with both dosing schema and a promising dosing schedule, which we now plan to take on to a recommended phase 2 dosing so that we can explore the combination of this agent with other agents and also the activity as Approximab dex combination alone.
Okay.